When heart failure treatment reaches its limits, the heart muscle begins a visible struggle. Even on an optimized medical regimen, the muscle can lose the strength required to pump blood effectively, causing the patient's condition to slip backward. This specific clinical state is symptomatic HFrEF, heart failure with reduced ejection fraction. It describes a patient whose left ventricle is pumping out less than 45% of its blood volume with each contraction, leaving them fatigued and short of breath. This infographic panel identifies the precise moment that deterioration becomes a crisis. We look for a clear, worsening event, defined as a hospitalization for heart failure within the last 6 months, or a sudden need for urgent outpatient intravenous diuretics. Once these triggers occur, the current therapeutic approach has reached its ceiling. Simply maintaining the status quo guarantees further decline, requiring a transition to a new, targeted intervention. A failing heart broadcasts invisible cellular distress signals directly into the bloodstream. As the cardiac walls stretch and strain under increasing pressure, they release specific proteins called natriuretic peptides. The Biomarker warning signals panel quantifies this distress. To be eligible for this intervention, a patient's BNP levels must reach at least 300 picograms per milliliter, or their NT-proBNP must cross the 1,000 mark while in normal sinus rhythm. The clinical data further narrows the target. The most significant benefits appear in patients under 75 years of age, who are categorized in NYHA functional classes 3 or 4, meaning they experience severe symptoms with even minimal physical activity. Research also highlights a specific proven advantage for patients who are unable to tolerate ARNIs, a major class of standard heart failure medication. Elevated biomarkers and these specific demographic markers identify the high-risk candidate whose survival depends on this specialized therapeutic lifeline. Administering Vericiguat follows a rigid progression. A 3-step ladder illustrates calibrating the dose to build tolerance. The ascent begins at 2.5 milligrams daily with food. Tablets can be crushed. The dose doubles every 2 weeks, reaching a 10 milligram target. This disciplined approach yields high success in a clinical setting. Approximately 90% of patients successfully navigate this climb to reach the final 10 milligram target. Utilizing this slow mathematical escalation allows a compromised cardiovascular system to adapt to the new chemical support without triggering a physiological shock. This climb requires uncompromising surveillance of a patient's vital signs, with a specific focus on blood pressure limits. The rule for initiation is absolute. A patient's systolic blood pressure must be at least 100 millimeters of mercury before the first dose. The adverse effects row reveals symptomatic hypotension affects 15.4%. If systolic pressure drops below 90, therapy pauses. However, the initial blood pressure drop averages just 1 to 2 points more than placebo. The side effects row lists anemia at 7.6% and dizziness at 6.7%. This drug is versatile. Patients over 65 or those with mild to moderate kidney and liver impairment require no dose adjustments. However, it must be avoided in patients on dialysis, those with an eGFR below 15, or those with severe hepatic impairment. Maintaining a high margin of safety depends entirely on the clinician's rigid adherence to these specific hemodynamic and organ function boundaries. Patients with advanced heart failure exist within a complex pharmacological ecosystem, often taking a wide range of foundational medications simultaneously. The seamless integration panel shows that Vericiguat coexists safely with existing standards of care. It can be deployed alongside ARNIs, ACE inhibitors, beta blockers, MRAs, and SGLT2 inhibitors without conflict. Because there are no clinically significant interactions with these core drugs, simple once-daily dosing aids compliance for patients who are already managing multiple medications. There are, however, lethal boundaries. As indicated in the Prohibited Pairings panel, Vericiguat must never be combined with SGC stimulators like Vericiguat or PDE5 inhibitors like sildenafil. Clinicians must also use extreme caution when using long-acting nitrates. These specific drug combinations cause excessive vasodilation. Stacking them together can lead to a catastrophic drop in blood pressure, making these boundaries essential for systemic stability. The most severe limitation is found at the very top of the clinical chart. The red contraindications row highlights a boxed warning regarding pregnancy. Clinicians must verify a negative pregnancy status and ensure the patient is using effective contraception before therapy can begin. Vericiguat acts as a precisely escalated ally to foundational heart failure therapies, providing a specialized layer of support when standard drugs reach their functional limit. By tracking biological markers, following a disciplined titration schedule, and respecting chemical boundaries, clinicians can intercept a patient's decline. The result is a transition from a dangerous worsening event into a highly controlled, data-driven rescue.